tell me. You can talk to me or you can message. واضح يا شباب? Okay, so this study session is going to be about clinical evaluation of groin hernia. So we talk about the hernia, we talk about types of groin hernia.
الصوت يروح إذا تكلم.
الصوت يقطع مرة ما نسمع شيء وفي صدى عندك.
طيب أنا خليني أطلع الهيدسيت. واستخدم اللابتوب ونشوف كيف. طيب يا شباب, can you hear me well now? Can you hear is this better? هذا أفضل؟ تمام. So this lecture is going to be about groin hernia. As I mentioned, we'll talk about the definition of hernia, we'll talk about the etiology, cause of hernia, and the clinical evaluation of those patients. Okay. لحظة يا شباب, give me 1 minute please. Just give me 1 minute.
دكتور تقدر ترسل المحاضرة؟
Yes I can, بس بعد السيشن برسلها لكم إن شاء الله بإذن الله. طيب. Now already, I think you have been introduced to how to examine a patient with hernia. So we'll talk about this a little bit later in the presentation. So first of all, what is hernia? This is a very important question that we need to answer first of all. And this definition will give you also a clue about the clinical complications and even the manifestation which can be encountered in a hernia. طيب, can you hear me well يا شباب? Still, can you hear me well?
مظبوط يا دكتور 100%.
Yes, we can hear you well.
Yes. So hernia, as you can see in the slide, is the bulge part of the contents of the abdominal cavity through a weakness in the abdominal wall. So in very basic terms, an organ which usually lies within the abdominal cavity will come to lie outside the abdominal cavity. Okay, and this is usually happy through the anterior abdominal wall. Okay, if we consider the causes of herniation, or what causes herniation in general, actually basically there are two main reasons. First of all, either the anterior abdominal wall is weak for any reason. This can happen because of the muscles are becoming weak, or the muscles they have lost their nerve supply, or they have been weakened by surgical incision whatsoever. Okay, so basically there could be a weakness in the anterior abdominal wall which let contents to move outside the abdominal cavity. And the other reason is actually an increase in the intra-abdominal pressure. This rise in the intra-abdominal pressure can push the contents of the which lies usually normally inside the abdomen to outside. So these are the reasons of herniation in general. And definition of hernia in general. In this lecture, we are going to focus on groin hernia. Anybody can tell me what do you mean by a groin? When I say groin, what do you mean by groin? So what do you mean by a groin?
Groin area, doctor.
Yes. What is it? Can you describe it? Can you describe what is the groin? Where does it lie? Not the whole thigh. I'm sure.
Between the scrotum and the right iliac fossa.
Yes. Any other answer?
Yes, doctor. I think around the genital organs.
Yes. Any other answer? What do you mean by a groin? What's a groin? Groin
below the spinal ligament.
Yes. When we say a groin, we are talking about the upper medial aspect of the thigh. We are talking about the upper medial aspect of the thigh. This is what we call by a groin, and of course the adjoining parts of pubis and the scrotum. Okay, so mainly we're talking about the upper medial aspect of the thigh. This is what we mean by a groin. Okay, so groin hernia is a hernia which lies in this space, in this area, in the upper medial aspect of the thigh. Okay. Yes. So as I have said, there are two main reasons for herniation, as I have mentioned in the last slide. And now we can mention some details under each one of these two main causes. So, for example, if we took weakness in the anterior abdominal wall, as I have already mentioned, that this weakness can be due to weakness in the muscle. The muscle can be get weakened. For example, if the patient has got a collagen disease, or the patient has got a chronic disease, or he is malnourished, or he has a neurological disease, or the muscles have lost their nerve supply, or they have been denervated by means of trauma or pericyclic infection or whatsoever. Okay, and this can also happen at there are certain areas which are basically weak because of the structure of the anterior abdominal wall. Areas, for example, are areas where structures enter and leave the abdomen. And the classical example here, once we are talking about the groin, we are talking about the inguinal canal and the femoral canal. These two canals allow some structures to pass either in the abdomen. Okay, so these canals are areas of natural weakness, and you can get herniation through these areas. So here there are basic weakness in the structure of the anterior abdominal wall. Okay, this is on the left side of the slide. On the right side, if we consider increased intra-abdominal pressure, this can happen due to strain for any reason. The patient can be a construction worker who lifts, for example, heavy weights, and this straining which happens every day and day can result into herniation. But any other reason of straining, like for example, patient have got a chronic cough, for example, patient have got emphysema, for example, airway obstruction, or patient have got chronic constipation, or elderly patients who strain to urinate, like for example, patients who have got a benign prostatic hyperplasia, or if the patient has got an intra-abdominal mass or ascites. All these conditions increase the intra-abdominal pressure, and they can predispose the patient for development of a groin hernia. Okay, and these causes are also important when you are evaluating the history of the patient, because if you are taking history from those patients, then you have to find out whether they have any reason of straining, for example, like chronic cough, constipation, and so on, or if they have some weakness in the anterior abdominal wall by means of surgery, for example, or by means of any systematic disease. Okay, so these are the causes, and at the same time, they have to be evaluated when you are taking history from the patient, as I will show you in the coming slides. This slide shows you, sorry. This slide shows you the anatomy of a hernia. This slide shows you the anatomy of the hernia. So as you can see here, this is the anterior abdominal wall, okay, through which this wall there is weakness, and through this weakness you get what? Herniation of intra-abdominal content. So for example, in this slide, bowel, which usually lies inside the abdominal cavity, it comes to lie outside. Okay, when it does so, I mean when it comes to lie outside like that, this will subject the bowel itself for complications. For example, the blood supply at this area, which is the narrowest area, can be cut, and this can result into ischemia here. And ischemia can be followed by perforation. Okay, and we'll talk about the complications which can be encountered in a hernia at the end of this presentation. Okay, now look at the diagram or the photo on the left side, on your left side. Here you can see what you can see the schematic representation of a hernia. Okay, so what do you see here? This is the abdominal cavity, and this is the defect. This is the defect through which the contents comes outside. The distal part here, this is known as the fundus. Distal part here, this is known as the fundus. Okay, and the widest part, the widest part is known as the body. This is the body of the hernia. Okay, and this is known as the sac, which covers the hernia. This is the sac of the hernia, like the silo or like the bag in which the contents of the hernia lie. Okay, and most importantly, in this diagram is this area. This is known as the neck. This is the neck of the hernia. Yes. One question, ya Shabab. One question. Why do you think this part is the most important anatomical part of a hernia? Why do you think this is the most important part?
Because it's narrow and maybe cause ischemia or defect in blood
Yes.
supply.
Yes. Actually, because actually hernias vary among themselves depending on the size of this neck. Some hernias have got a wide neck, and some hernias have got a narrow neck like this. Okay, the importance of this is that this area determines the risk of complication. As much as this area is narrow, then the risk of complications will be high because blood supply can be easily cut here if this area is narrow. While if this area is wide, then the risk of complication can be less actually because there will be some room. There will be some room for the contents to move here without being compressed. While if the neck is narrow like this, this can subject the hernia contents for compromise of the blood supply and ischemia. Okay, so this is the anatomy of a hernia in general. Okay, the most important part that you need to know is whether the neck is wide or not. Okay, yes. So we are talking about groin hernia, and here there are main two types of hernia. There are main two types of hernia, inguinal and femoral. When we talk about groin hernia, we are talking about two main parts, inguinal and femoral. Okay, so we'll talk about the clinical characteristics and features of each one of these two types. First of all, I would like to discuss with you some basic anatomy of the inguinal and groin region, because this is very important. Whenever you are confronted with a case of hernia, for example, in a clinical exam, be sure that they will ask you about anatomy. Be sure that they will ask you about anatomy, and even knowing the anatomy of the groin, this will also enable you to understand the clinical features of groin hernias, whether inguinal or femoral. Okay, so as you can see here, I'm pointing now. I'm pointing now to structure. What do you think is this structure I'm pointing to now?
Femoral vein.
This is the femoral vein. Yes. What is this structure? What is this structure?
Inguinal ligament.
Groin ligament.
The inguinal ligament. Now, what is this structure? What is this structure? This is the reflection. This is the reflection of the inguinal ligament. The inguinal ligament is inserted in the pubic bone, and then it reflected posteriorly. So, what do you call this area? Arch area, like arch.
Semillunar.
This is the lacunar. If you heard of it, this is a lacunar ligament. It's a very sharp ligament actually. It's just like a knife. Very sharp ligament. Okay. Yes. So what do you call this space? What do you call this space?
femoral ring.
What do you call? This is the femoral ring. This is the femoral ring, which is, as you mentioned, is lined medially by the femoral vein, laterally by the lacunar ligament, superiorly by ligament, and inferiorly or posteriorly by the pectineal ligament.
معلش دكتور عدل آخر معلومة ننقطع الصوت.
Yes. So this is the femoral canal. This is the femoral canal or the femoral ring, which is lined medially by the femoral vein, laterally by the lacunar ligament, superiorly by the inguinal ligament or anteriorly, and inferiorly by the pectineal ligament. Now, what do you recognize here? What do you recognize here in this canal or in this ring? What do you recognize here?
It's a weak point of the anterior abdominal.
Yes, and what else? Think of the borders. Think of the borders. What do you think of the borders? What do you think of the borders?
Norway, doctor.
Semilunar.
What do you think about the border from this canal?
inguinal, lateral.
Yes, there is a ligament here, and there is also ligament here, and there is also ligament here. So there are, out of the four borders of the canal, there are how many ligaments?
Three.
Three ligaments.
Three ligaments. And what do you think? This is tough or this is easy, or what do you think?
Tough.
It will be tough.
Actually, yes, actually this is tough. Yes, actually this is tough for the contents which pass from here. Actually, the femoral hernia passes through this area, through the femoral canal, and having three out of the four borders made by ligaments, this will make this space is very tight, and this explains why femoral hernia actually strangulate at a very high rate, more than inguinal hernia. Okay. Now let us move to see this structure. What do you think of this structure?
Inguinal canal.
Yes, and what is this structure which lies in?
Spermatic cord.
This is the spermatic cord. And what lies here in females? This is a male. Of course, this is a male. What lies here in a female?
Female ligament.
A round ligament.
Round ligament, yes. A round ligament lies here in there. So the inguinal canal is a canal, as you have mentioned. The contents, the spermatic cord enter through this area, which is the internal ring, and comes out through what? Through this area, which is the external ring. Okay. So inguinal hernia appears to the surface through the external inguinal ring, and femoral hernia appears to the surface through the cribriform fascia, cribriform fascia. Okay. Yes. So if I want, I don't know whether I can move this. Yes. I want just to move this, but I cannot actually. I will try to draw. I want just to one of the most important landmarks here to differentiate actually between femoral and inguinal is the pubic tubercle. And I can just show where is it. Yes. This area. Sorry, just 1 minute. Cancel. You can use this. Yes. So this area, you see this area is the pubic tubercle. This is the area of the pubic tubercle. Okay. So an inguinal hernia appears here. Inguinal hernia appears here. Okay, which is 2 centimeters above the medial. 2 centimeters above and medial. While femoral hernia appears here, the side of the cribriform fascia. Here, this area. Okay. So you can see.
Again, last point.
يقطع دكتور. ما سمعت شيء دكتور.
معلش الكونكشن، المشكلة في الكونكشن.
طيب تعيد آخر نقطة دكتور.
طيب. This is the pubic tubercle. Okay. I will show you. This is the pubic tubercle. Okay. This is the pubic tubercle. 2 centimeters above a median. Here appears the sac of what? The inguinal hernia. And 2 centimeters below and lateral appears what? The size of the sac of femoral hernia. So inguinal hernia 2 centimeters above a medial, while femoral hernia 2 centimeters below and lateral. Okay. Another important landmark here is this one. What is this?
Inguinal ligament.
Inguinal ligament. So also we can say what? We can say the sac of inguinal hernia usually lies above the ligament, while the sac of femoral hernia usually lies below it. Okay. So these are 2 important landmarks for you, anatomical landmarks for you, in order to differentiate between which one is femoral hernia and which one is what? Which one is inguinal hernia. So 2 points. First of all, we say inguinal hernia appears 2 centimeters above a medial, the pubic tubercle. Femoral hernia appears 2 centimeters below and lateral. The other thing to differentiate is that inguinal hernia usually lies above the inguinal ligament, while femoral hernia usually lies where? Below it. Okay? Is that clear, ya shabab?
Yes, clear. Thank you.
Yes, doctor.
Clear. Yes. So as I have said, groin hernia are mainly two types, inguinal and femoral. Inguinal hernia is further divided into direct and indirect. The indirect type passes through the both rings, the internal ring and the external ring. And it is the most common type, accounting for 2/3. So 2/3 or almost 65% or 66% of inguinal hernias are of the indirect type, while only 35% are of the direct type. A direct hernia passes only through the external ring. It does not pass through the inner ring. So from where does it come? From the abdomen. It comes through the posterior wall of the inguinal canal. Usually this wall, and this wall actually is weak because it is made of fascia transversalis. It's made of fascia transversalis, and that's why it's weak. Okay, this type of hernia, the direct hernia, usually happens due to weakness in the muscles, and that's why it's more exhibited in elderly patients rather than adults. Okay, rather than adults. So we can say that an indirect hernia is mainly related to the increase in the intra-abdominal pressure for any reason. Heavy weight lifters, construction workers, those who have chronic cough, and so on. Yes, Faisal.
معلش دكتور اللي تكون بالويك ماسلز الفيمورال اللي ما سمعتها.
No, inguinal. Inguinal has got two types. And indirect is usually related to increase intra-abdominal pressure, usually straining, heavyweight lifting, construction workers. Yes, Abdul Majid. Yes, I can. Sure. Yes. So see here, this is the inguinal canal. It is a canal. It has got an entrance opening and exit opening, and has got anterior border, superior border, inferior border, and posterior border. Okay. So this is the anatomical site. This is the anatomical landmark here. Anatomical landmark of the internal ring lies here, and this is the external ring. So a direct inguinal hernia passes through both rings. An indirect passes through the internal and the external. Okay. And by the way, here there are vessels which are branches from the femoral artery and femoral vein, which passes upwards like that. This is known as the inferior epigastric vessels. There are also important landmarks in hernia surgery. Okay, I will show you now how they are important. This is the indirect, comes through the internal ring, goes through the internal ring and the external ring, while the direct type comes directly from the abdomen through the posterior wall. So it comes through here, the posterior wall, which is weak, and then it appears or it passes through the external ring. Okay, so this is the difference between a direct or indirect. The indirect passes through both things, while the direct passes through the only the external ring. Okay, so what do you think? What do you think the relation of the sac in case of direct and indirect in relation to the inferior epigastric vessels, which lies here?
I think direct one will be medial to the inferior epigastric artery, and the indirect will be lateral.
Yes, very good. And also, I'll tell you about one important anatomical triangle, which is lies here. This triangle is made by, this limb is made by the inferior epigastric vessels, and this limb is made by the lateral part of the rectus muscle, and inferiorly it is lined by the inguinal ligament. Do you have any idea what we call this? What we call this triangle? Inguinal ligament here, inferior epigastric vessels here, and the lateral part of the rectus muscle here. What do you call this triangle? From anatomy, do you have any idea?
Femoral triangle.
No, this is
فيه كلمة
this is
باخ أو هاسلباخ
yes,
زي كذا.
Hasselbach. Yes, Hasselbach. Very good. Yes, this is known as Hasselbach. This is known as Hasselbach. Okay. So the indirect hernia lies outside, while the direct hernia lies within this triangle. Again, this is also an important landmark in hernia surgery. So is that clear? Is that clear?
اي واضح
Yes.
دكتور الله يعافيك.
In groin, femoral hernia, on the other hand, accounts only for 10% of groin hernias. So 90% of groin hernias are of the inguinal type, and only 10% are of the femoral type. So it appears here very clearly that inguinal hernia is more common than femoral hernia. Okay, only 10th of all groin hernias are femoral. Okay, the inguinal is the commonest in both sexes. Is commonest in both sexes, but still it is more common in males than in females. It's more common in males than in females. Okay, so inguinal hernia is more common in both sexes, in males and females. It's more common than femoral hernia, but it is more common in males than in females. Okay, femoral hernia on the other hand, it is more common in females rather than males. Okay. Here I got one question for you, ya Shabab. Why do you think femoral hernia is more common in females than in males?
Maybe due pregnancy.
Yes. What does pregnancy do?
Increase the intra-abdominal pressure and dilate the muscles.
Yes. Any other answer why femoral hernia is more common in females?
الدليفري يضعف المسكس هذه.
Yes. طيب in general what would you say in general?
عشان دكتور سبلمنتك كورد.
No, I would say that the femoral canal in females is wider than males. I would say that the femoral canal in females is wider than in males. And there are actually three reasons. Why the femoral canal is wider in females than in males. Okay, and pregnancy is one of these causes, but not in relation to muscles. Pregnancy causes actually elongation and elasticity or weakness in the ligaments. I have mentioned already that there are three ligaments which line the borders of the femoral canal. These ligaments are stretched by means of pregnancy and delivery, and that's one reason why these ligaments results into wider canal in comparison to males. Okay, and still there are two other reasons, and I prefer to leave it as homework for you. What do you think? I will leave it as homework for you to find out the two other reasons which result into a femoral canal in females wider than in males. Do you accept this homework?
Yes, okay, no problem.
Yes.
It's okay.
Yes, pregnancy is one, and there are two other causes. So we would like to know why femoral canal is wider in female than in males. Now, if you are confronted with a patient who have got an inguinal hernia, how do you work out clinically the patient? Actually, clinical evaluation means what? Means history taking and physical examination. History taking, there are main three questions or three key points or key questions that you need to find out, or you need the patient to answer for you in order to find whether it's a hernia or not. The first thing that we would like to determine whether this is a hernia or not a hernia. Is it a hernia or not? Because a little differential diagnosis actually is not few. There are numerous causes of a groin swelling. One of these causes is a hernia, but still there are other differential diagnoses. So first of all, we would like to find out whether it is a hernia or not. So what do you think? Which question can enable you to find out whether this hernia is whether this swelling is a hernia or not?
Does it reducible or not?
الكف impulse دكتور.
Yes. No, cuff impulse is by examination, but now at level of the history taking. So the patient will tell you that there is a swelling in the groin, for example. sometimes he might not have a swelling, clear swelling. Sometimes he might complain of some discomfort or dragging sensation in the groin area. But most of the time, the patient will tell you that I have got a swelling in my groin. So what will tell you that this swelling is a hernia?
We ask the patient if he can reduce the swelling.
Yes, the patient will tell you that I have this swelling, for example, for the last 3 or 4 or 5 months or so, and this swelling tends to decrease when I lie down, for example, and it tends to increase or it tends to reappear or appear when, for example, I climb stairs or run or play football, for example, or do any sort of exercise. Okay, so swelling which usually reduces when the patient lies down and increases or reappear if the patient stand or walk or climb the stairs and so on. So you will find out that the swelling have got a relation to position, the patient position. Okay, so this is the key. That means that this is most likely a hernia. Okay, so this is the first thing that you would like to determine in your history. The second point, if this is hernia, is it simple hernia or complicated hernia? I will talk about complications, but what I mean by complication, I mean incarceration or strangulation or obstruction. Okay? Yes. So how would you find out? How would you find out that the hernia is simple or complicated? How would you find out whether it is obstructed or strangulated?
severe pain,
السبتم دكتور، مثلا اذا كان سفير بين وتندرنس هذه سترانجوليتد هيرني.
Yes.
constipation,
Yes, the patient first of all might tell you that I am not able to reduce the hernia for the last 1 or 2 days. The patient might tell you this. Okay, and what is he providing you? He's providing with information that this hernia is most likely obstructed or complicated. Okay, yes. The other thing, if the patient have got pain, if there is pain in the swelling in the hernia lump, this hernia is most likely complicated of obstruction or strangulation. The third thing, that if the patient have got features of bowel obstruction, if the patient have got features of bowel obstruction like, for example, vomiting, absolute constipation, abdominal distension, and abdominal pain. If the patient have got these features of subobstruction, again, this will clue that this hernia is most likely complicated. Okay, so this will tell you whether the hernia is complicated or not. So now we work out 2 questions. First of all, is it a hernia or not? The second question, whether this hernia is simple or complicated. And the most important, and thirdly, an important question is we want to know what is the underlying cause of the hernia. We want to know what is the underlying cause of the hernia. So which questions you think would enable you to find out the underlying cause of hernia?
الاوكوبيشن دكتور حق البيشن.
Sorry?
الاوكوبيشن حق البيشن مثلا
Yes, very good. Occupation, yes.
if the female have pregnant before,
Sorry?
if she have pregnant or babies,
If she is pregnant, yes. What else?
If there is chronic cough or chronic constipation.
Chronic constipation, yes. What else?
heavy weight that she load or elevate heavy weight.
He lifting heavy weight, job or occupation ممكن يكون construction worker فهذه كلها related to the job. Yes, what else?
Maybe in case of stringing in micturition, in case of benign prostatic hypertrophy.
Yes.
Or
In an
trauma,
elderly
doctor.
male, you ask
Trauma.
about difficulty in passing urine, difficulty in micturition. Yes. What else?
If he has had trauma,
Has what?
Medical process in the abdomen, maybe.
trauma.
Yes, history of trauma. Yes, history of trauma can result into trauma to the right iliac foot. The muscles or the lower abdomen can result into herniation. Yes, what else? Anything else in the history to be worked out, to be investigated? History of chronic disease. If the patient have got a chronic disease, a chronic debilitating disease, it can also result into muscle weakness and can predispose the patient for formation of hernia. History of surgery, history of abdominal surgery, which might result into de-innervation. The classical example here is the incision for appendectomy. The incision for appendectomy causes sometimes injury to the ilioinguinal nerve, sometimes causes injury to the ilioinguinal nerve, which supplies the muscles that part of them that line the inguinal canal and can result into inguinal hernia. Okay, so history of surgery again can be worked out. History of abdominal distension, abdominal the patient have got abdominal distension for any reason like ascites or abdominal swelling or whatsoever. Okay, collagen history of chronic disease as part of the collagen disease. Okay, yes, all of these questions has to be worked out in the history. Has to be worked out in the again, I will tell you about important three key questions in the history. First of all, is it hernia or not? Is it hernia or not? Okay. The second question, complicated. Okay. And the third important question, what is the most likely underlying cause? What is the most likely underlying cause? This is at the level of the history. And then after that, you go to the physical examination. Okay. The patient has to be examined while he is standing. The patient has to be examined while he is standing. I will not talk about the details of examination because I think this already has been covered in the simulation sessions. But I will mention here the points which are relevant to the hernia. So the most important thing that the patient has to be examined while he is standing because the gravity will help you to make the swelling clear for you. Because sometimes the swelling might not be clear. So examination of the hernia lung is just like examination of lung anywhere in the body. Okay, so the 5 S's like a size, a shape, and overline the skin. You follow these things. But just I want to ask you one question in each one of these. How do you think the size? Sorry. How do you think the size will help you while you are examining the hernia? Just give me one comment here, please. What do you think the difference
We
in
can
size?
differentiate whether if it's omentocoel or if it's part of the intestine.
Yes, actually here I'm talking about the size. So I would say here that usually the lump or the sac of inguinal hernia is usually larger than the femoral hernia. Why do you think this happens? Can you explain?
ممكن عشان دكتور اللي هو النارو نيك.
Yes, narrow neck and the neck which is lined by 3 ligamentous borders. Okay. Yes. What do you think the side? How would the side help you? How would the side help you?
دايركت اور فيمورال يعني تميز لي اذا راحت للسكروتم مثلا اذا راحت للسكروتم هذه اندايركت.
Yes, very good. Usually, hair, inguinal hair, which lies in the scrotum, this is most likely indirect. Okay, but how can it help you to differentiate between femoral and inguinal?
Relation to the pubic tubercle, we can know if it's femoral or triangle.
Yes, and what else? Relation to also the inguinal ligament. Yes. How would the shape help you to differentiate between inguinal hernia and femoral hernia?
Yes, if it's protruding to anteriorly, maybe it's femoral. If it's oblique, maybe inguinal.
Yes, I'm also looking for this hourglass shape. Yes, I'm looking also for this hourglass shape. Usually, inguinal hernia have got an hourglass shape. This is very characteristic of inguinal hernia. So again, a shape here can help you to differentiate between inguinal hernia and femoral hernia. Yes. When you go to the examination, then again the examination of a lung, you start by 2 tests, tenderness and temperature, and then you test. As part of the inspection, you test for visible cuff impulse, and when you come to palpation, again you test for palpable cuff impulse. The most important test here is a reducibility test. I think we have talked about that in the simulation sessions, but in general here, you ask the patient to lie down. He was standing, of course. Now you ask him to lie down. You ask him to review the hernia by himself. This is very important because you might hurt the patient if you did it yourself. Okay, so ask the patient to lie down, ask him to review the hernia himself, and then occlude the internal ring. Occlude the internal ring, and after that, ask the patient to stand again and cough. Ask him to tilt his face away from you, ask him to cough. If the swelling reappeared, then this is most likely a direct hernia. And if it did not reappear, that means definitely the swelling is passing through the internal ring, and in this case, it will be what? An indirect inguinal hernia. Okay, so this is not a finger occlusion test. Finger occlusion test. Yes.
In the femoral hernia, there is no cuff impulses. Is that correct?
Yeah, maybe yes, because the sac is small and tight. The sac is small and tight. So you might not be, you might not be able to feel a cuff impulse. But mostly, if the hernia is not complicated, you will be able to see and feel a cuff impulse. If the hernia is not complicated by means of obstruction or strangulation. Okay. Yes. I will show you quickly these diagrams of patients who presented to the hospital with these swellings, with these lesions. First of all, looking at this swelling on the right side, tell me what this hernia is most likely. What this hernia is most likely.
Indirect.
No, inguinal rotation, we don't know whether it is direct or indirect unless we do a finger occlusion test. By inspection, you cannot tell me. This is most likely inguinal. And this one on the left side, femoral. طيب tell me why. What guide?
دكتور الصورة الثانية فيها ثنتين هرنيا صح؟
Focus on this. Focus on this one. Focus on this one. So why this inguinal? Why this inguinal?
The right side because it's oblique in shape.
Yeah, this is the area of the pubic tubercle here. It should be here. Pubic tubercle should be where? Here. Yes. So this is swelling. This is swelling lies where? In general, above and medial the pubic tubercle. Okay. While this lies where? This is the pubic tubercle. This mostly lies where? Below and lateral. Another guide, important guide here, that this is the inguinal. This is the inguinal ligament. No. This is the inguinal ligament. This is swelling lies above the inguinal ligament, so it's most likely inguinal hernia. While this is swelling lies where? Below the inguinal ligament, so this is most likely what? A femoral hernia. Okay. This shape here shows you. This shape here shows you the hourglass. The hourglass. This is the hernia sac. This is the hernia sac, which is constricted here at the site where it emerges through the external ring. So this constriction here will result into a shape which is similar to an hourglass. And this explains the hourglass shape of inguinal hernia. Now, what do you see here? What do you see here in this picture?
Inguinal hernia.
erosions.
Yes, here there is redness, and there is skin peeling. Possibly there is here some ulceration here at this area. So it looks like this area looks like inflamed. Looks like what? Looks like inflamed. And actually, this patient does not have a hernia. He proved to have inguinal lymphadenitis. This patient proved to have inguinal lymphadenitis. Okay, and this will take us to talk about the differential diagnosis. Not any groin swelling is a hernia. Okay, so we need to determine the differential diagnosis. Actually, the list of differential diagnosis is not short. Okay. And here is the list of differential diagnoses. Okay, it could be a saphenous varix, which is a venous dilatation from the saphenous vein, or it could be an aneurysm. It could be an aneurysm arising from the femoral artery, or it could be an abscess, a psoas abscess. It could be an inguinal lymph node, could be solid, firm, or it could be inflamed, giving rise to abscess formation, like the photo that you have seen. I will show the picture here. Yes, it could be an ectopic testis in males. It could be an ectopic testis. Testes usually develop in the abdomen and then they descend downwards in the scrotum. If the descending or descent of these testes is arrested somewhere in the groin, you can also find an ectopic a lump here. Like it could be lipoma of the cord and it could be incisive hydrocele of the cord. So you see, there is at least seven differential diagnoses of a groin hernia, a groin swelling, and all this has to be borne in mind while you are conducting examination. For example, what is the most important feature in examination supporting diagnosis of a Safina varix? Safina varix. Do you hear me?
سامعينك يا دكتور بس ما ندري والله.
Safina varix. What is the criteria of venous swellings in physical examination? What's the most important feature?
تكون تورشس.
No, if the hernia is reducible, what about the hemangioma?
Compressible. We can compress it.
They are compressible. Yes. So the most important feature here that will be compressible. What about the femoral artery aneurysm? What about an aneurysm?
True pulsation. True pulsation.
They will be true pulsating. There will be a thrill. And there will be a bruit by auscultation. Yes. Okay. So examination for the color, examination for the consistency, examination for compressibility. Okay. All of these things are very important. This photo actually is of a patient who have got a huge inguinal hernia. So you see sometimes this hernia can grow, the size of this hernia can grow to a very large one. Sometimes they can reach the knee. As you can see here. Yes, so this is a huge inguinal hernia. What do you think the type of this inguinal hernia, direct or indirect?
Indirect.
Indirect. Because listen to this sentence. Direct inguinal hernia almost never descend into the scrotum. Okay, direct inguinal hernia almost never descend into the scrotum. While these hernias that usually descend in the scrotum and reach very large size like this are usually are of the indirect type. Okay. So what are the complications that can be encountered in a hernia? Actually, in general, there are three. I will just concentrate on the first two, which is obstruction and strangulation. So would like to know what are the features, whether by history or by physical examination, which will enable you to find out whether the hernia is complicated or not. We have already talked about the history, points in the history, and we'll talk about points in the physical examination. So if the hernia is obstructed, of course, as I have already mentioned, the patient will tell you that I'm not able to reduce it for the last hours or days or so. Okay, and again, when you conduct the physical examination, you will find that the hernia is tense, and it cannot be reduced, okay, and there will be an absent cuffing pulse. Okay, so these are the main features of obstruction. That the hernia site is tense, it is irreducible, and there is no cuffing pulse. Okay, is that clear? Now regarding strangulation here, in addition to the features of obstruction that we have already mentioned here, the patient will have very severe tenderness, which sometimes we call exquisite tenderness. Sometimes he might have an erythema or redness over the overlying skin, and the patient might have got features of bowel obstruction like abdominal distension, increased peristalsis, and so on. Okay, so locally, if the hernia is obstructed, it will be tense, irreducible, and no cuffing pulse. If it is strangulated, in addition to this, you will get what? Severe tenderness and you get also what erythema or redness over the overlying skin. Sometimes the patient might enter into collapse, and if he has also features of vasosuction, this will make a diagnosis of strangulation is also expected. So, is this clear? Is it clear difference between obstruction and strangulation?
Yes.
Yes, clear.
Yes. So in obstruction, there is no tenderness and no erythema. In obstruction, there is no tenderness and there is no erythema. If there is severe tenderness or exquisite tenderness and erythema over the overlying skin, then this is most likely the hernia is strangulated. The hernia is strangulated. I will show you now. I will show you this picture. This picture is taken for a patient who have got a groin hernia, inguinal hernia, which is complicated by strangulation. So, can you describe what do you see? Can you describe what do you see?
Discolorations of the
Discoloration, redness.
Yes. Yes. This swelling in general. This is swelling in general. Is the lumbar hernia. This
دكتور
erythema is
انقطع
quite
الصوت.
suggestive of what? Quite suggestive.
لو تعيد اخر كلمه،
Sorry.
اخر جمله لو تكرمت انقطع
This,
الصوت.
this, this, this is the lumbar general. You see, this is the lumbar general. Okay, it looks like an inguinal hernia because this is the inguinal ligament. It looks like about the ligament, and this redness here, this redness or erythema here, is quite suggestive of what? Quite suggestive of strangulation. Okay. Now, what do you expect to find if you palpate? Now, this is swelling. What do you expect to find?
severe tenderness.
Yes. Here, the most important thing that the patient will have got severe tenderness, not pain. Pain is pain by history. But now we are in physical examination. So here we talk about tenderness. When we talk about history, we talk about pain. When we talk about examination, we talk about tenderness. So here the patient will feel severe tenderness. Okay. And this also here on the right side, this diagram shows you the complication which happens in a hernia. So this is the hernia, and this is the bowel which is lies inside. Now, in strangulation, you get compromise to the blood supply. Then the neck will be very narrow. And this will compromise and cut the blood supply, and then what you get ischemia, necrosis, and perforation, which can happen here for the intestine. Okay, this one happens in strangulation. Okay, yes. So this is the last slide in my presentation. We have talked about the definition of hernia. We have talked about types of groin hernia, inguinal and femoral hernia. We have talked about the differential diagnosis. We have talked about how do you work up clinically a patient who have got a hernia. How do you take history? What are the important points in the history that you should not forget? And how do you conduct physical examination? And what are the features of clinical features of obstruction and strangulation, which are the most important complication that can be encountered in a hernia. Okay. So I hope what I have mentioned is clear. And now, if you have got any questions or anything which is not clear, please do point to me. Yes, yes, Abdurrahman.
السلام عليكم دكتور بالنسبه الدكتور عماد تقدم في محاضرات الى غدا.
Yes, أنا الآن سوري الآن هعطيكم محاضرتين اللي فيها محاضرات بكره حقت السكين حقت السكين ليكتشرز هعطيكم عنها الحين وبكره الدكتور القحطاني والدكتور عماد هعطيكم محاضراتهم.
يعني بكره الدكتور القحطاني والدكتور عماد من بكره يبدون ها؟
من بكره واليوم حواصل معاكم two more lectures about the skin lesions.
طيب شكرا لك.
اوكي طيب اي كويستشن يا شباب؟
واضح يا شباب؟ شكرا.
لا بالله في الواتس لان الصوت يقطع.
نعم
يا باقي لها يعني شيء كبير. اليوم القحطاني والعماد محاضراتهم راح تتأجل الى بكره بدال محاضرات الدكتور احمد. اليوم الدكتور احمد راح يعطيك محاضراته حقت بكره باختصار.
ايوه خلاص تمام كذا الحين والله.
Raise up your hands, please. Raise up your hands, please, for attendance, please.